Hello everyone and welcome to today's lecture on pharmaceutical toxicology. So starting with salicylates. So salicylates are derivative of salicylic acid and include acetyl salicylic acid, sodium salicylate and methyl salicylate. Acetyl salicylic acid is an odorless, white crystalline powder with an unpleasant saline taste. Sodium salicylate occurs as odorless, white scaly crystals with the same unpleasant saline taste. If we talk about methyl salicylate, they are colorless liquid with aromatic odor and sweetish taste. Salicylates for therapeutic use are available as tablets, capsules, powders, effervescent tablets, and liquid preparations for ingestion, rectal suppositories, and as liniments, creams, and lotions for topical application. Uses of salicylates. They are used as antipyretics, analgesics in the treatment of rheumatoid arthritis. Low-dose aspirin is used in the prophylaxis of cerebrovascular ischemic events and angina pectoris. Mode of action of salicylates. So these salicylates stimulate the respiratory center in the brainstem, leading to hyperventilation and respiratory alkalosis. They also interfere with Krebs cycles, inhibit the production of ATP, and increases the lactate production, leading to ketosis and a wide anion gap metabolic acidosis. In children, respiratory alkalosis is quite transient and metabolic acidosis is the predominant feature. Coming to clinical feature, first acute poisoning. So early symptoms include nausea, vomiting, sweating, tinnitus, vertigo, and hyperventilation due to respiratory alkalosis. Lately, there will be deafness, hyperactivity, agitation, delirium, convulsions, hallucinations, and hyperpyrexia. Complications include metabolic acidosis, pulmonary edema, rhabdomyolysis, cardiac depression, thrombocytopenic purpura. Coming to chronic poisoning, which is also known as salicylism. So, this salicylism or chronic poisoning is characterized by slow onset of confusion, agitation, lethargy, disorientation, slurred speech, hallucinations, convulsions, and coma. Sometimes salicylism presents as pseudo-sepsis syndrome, characterized by fever, leukocytosis, hypotension, and multi-organ system failure. Treatment of salicylate poisoning. First of all, stomach wash should be done, which is beneficial up to 12 hours after ingestion. We can administer activated charcoal. Urinary alkalinization can be done along with hemodialysis. And lastly, supportive measures, which includes correction of fluid and electrolyte imbalance, correct the dehydration with 0.9% of saline. Hyperpyrexia must be tackled by cooling measures, correction of metabolic acidosis with sodium bicarbonate, and the correction of hypocalcemia with calcium gluconate. Autopsy findings. There will be petechiae in the skin. There will be erosion of the gastric mucosa. Black altered blood may lie in the stomach, and sometimes masked concretion of tablets are present. Petechiae in various organs and serous membranes, that is parietal pleura as well as pericardia. And lastly, there will be presence of pulmonary as well as cerebral edema. Now, moving on to the next drug, that is paracetamol. Paracetamol, also known as acetaminophen, and it exists as white, odorless, bitter tasting crystal or crystalline powder. Coming to the uses of paracetamol, it is used as antipyretic and analgesic, while fatal dose is approximately 20 to 25 grams. Clinical features. So, clinical features, first acute poisoning. This acute poisoning is divided into 4 stages: stage 1, stage 2, stage 3, stage 4. So, from half hours to 24 hours is stage 1. And the symptoms include anorexia, vomiting, sweating, and malaise. Stage 2 is from 24 to 72 hours, which is relatively symptom-free. There may be right upper quadrant pain and the liver function test may be abnormal. Stage 3 is from 72 to 96 hours. there is hepatic necrosis, which sets in with coagulation defects, jaundice, and encephalopathy. And lastly, we have stage 4 from 4 days to 2 weeks. If the patient survives the third stage, complete resolution of hepatic damage occurs in this stage, that is stage 4. Now, chronic poisoning. This is very uncommon, but cases have been reported wherein an individual has consumed large doses of paracetamol over a period of time for relief of chronic pain, which resulted in toxic hepatitis. This is more common in alcoholics and AIDS patients, in whom there is depletion of glutathione, and patients receiving other medication which are cytochrome P450 inducers, as for example, isoniazid, rifampicin, phenytoin, carbamazepine, and barbiturates. Now, management of paracetamol poisoning. First of all, stomach wash should be given, and this stomach wash is useful only in the cases with very early presentation, that is less than 1 hour. Then we can also administer activated charcoal along with antiemetic. The supportive measures include 10 to 20% dextrose for hypoglycemia, fresh frozen plasma if there is overt bleeding, then mannitol, dosage is 0.5 gram per kg, given over 10 minutes for cerebral edema. And if we talk about the antidote for paracetamol poisoning, it is methionine and N-acetylcysteine. Coming to the autopsy findings of paracetamol. So, liver may be enlarged and yellowish in color, and the microscopy reveals centrilobular necrosis. If we talk about the renal or the kidneys, then there is histological evidence of renal damage. There is cerebral edema also, and the cardiac findings in fatal overdoses have included subendocardial hemorrhages, fatty degeneration, and focal necrosis. Now, next drugs are anti-infectives. So, in this anti-infectives, we will mainly discuss sulphonamides. So, what are these anti-infective drugs? These anti-infective drugs are those which fight infections caused by bacteria, viruses, fungi, and protozoa, as well as infestations resulting from parasites such as helminths. Now, classification of anti-infectives. So, these are classified into two categories, that is antimicrobial agents and antiprotozoal agents. If we talk about antimicrobial agents, it includes antibacterial drugs, which are sulphonamides, quinolones, penicillins, cephalosporins, aminoglycosides, tetracycline, chloramphenicol, macrolides, antituberculous drugs, antileprotic drugs. And along with antibacterial drugs, we have antifungal drugs also. Now, in antiprotozoal agents, we have antimalarial drugs such as quinine, chloroquine, amodiaquine, quinidine, and mefloquine. Among antiamoebic drugs, we have diloxanide, furoate, quinidochlor, amethine, and dihydroamethine. And if we talk about the anti-helminthic agents, we have benzimidazoles, diethylcarbamazine, and niclosamide. Coming to the clinical features of sulphonamides. These sulphonamides are mainly used as antibacterials. They occur as white crystalline odorless powder with a slight bitter taste. Its clinical feature include, first is hypersensitivity reactions, which includes anaphylaxis, angioedema, drug fever, rashes, serum sickness, Stevens-Johnson syndrome, and vasculitis. If we talk about kidney, the symptoms include crystaluria, oliguria, and inuria. In hematologic symptoms, there is agranulocytosis, thrombocytopenia, hemolytic anemia. Then there is kernicterus in neonates, photosensitivity, neurologic, that is headache and insomnia. And along with it, we also have hypothyroidism, hepatitis, activation of quiescent SLE, and exacerbation of porphyrias. Treatment is symptomatic, and if we talk about the autopsy findings, then all internal organs will be congested. Kidneys have tubules blocked with sulphonamide crystals, and in bone marrow, we have aplastic in acute agranulocytosis. Now, moving on to the last drugs that are endocrines, and in this, we will discuss insulin. So insulin is a hormone which regulates carbohydrate and fat metabolism in the body. It's available in two forms. One is human insulin, that is humulin or novolin, and the another one is porcine insulin. This human insulin is more soluble than porcine insulin in aqueous solution, owing to the presence of threonine in human instead of alanine with its extra hydroxyl group. The clinical features of insulin poisoning. If we talk about the gastrointestinal tract, there will be vomiting, and the CNS symptoms include anxiety, behavioral changes, blurred vision, confusion, cramps, delirium, dizziness, drowsiness, fatigue, lack of balance, loss of consciousness, maniacal behavior, poor concentration, seizures, shock, slurred speech, tremors, weakness, and finally coma. The severe symptoms include tachycardia and hypotension. And dermal manifestations are profuse sweating only. If we talk about the respiratory system, it includes deep, heavy breathing. And in terminal stages, there will be brain damage and death if severe lowering of sugar persists for many hours. Coming to the treatment. So, first of all, glucose should be given. If it's given orally, then 10 to 20 gram should be given. If it's given IV or intravenous, then 50 ml of 50% glucose stat. Then continuous infusion of 10% glucose till the condition improves. Alternatively, we can also give dextrose or a high carbohydrate diet. And other than these two, we have to evaluate the CNS for signs of permanent damage. Thank you.